Well, who am I? I'm a doctor in Auckland. I trained in Auckland. I went to med school when I was about 17. I met my wife, who was a nurse on the ward when I was 4th year med school. I then nearly failed med school for 4th and 5th year because she distracted me. And then we got married, and then she one day told me, by the way, I've got into med school. And so at the age of 22, I went back to med school for another 12 years because we had 4 kids through her med school. And at the age of 33, we went to Canada and I finished my training. So by the end of all that, I was over med school. We'd done so many years that it's unbelievable. So I often bump into people now when I say, where do I know you from? And it's my wife's 3rd med school class, because every time she had a baby, she had a year off and carried through. So we know a bit about doctoring and nursing. And we've got 4 teenage sons. So at some point I'll vent about one of my sons during the talk. They've done everything you can imagine except for smoking pot that I know about. So it's very informal. I didn't quite know who the audience was, so some of the questions will be at quite a high level. So Simon, Hoare and Shannon here can answer those off the top of their head if they get to that point, okay? No, they said to me, we don't know some of the answers either. So on the side here is a couple of arrows, and this was just the outline of diabetes. And the big arrow at the top was actually see 95% type 1 diabetes. We'll see if the rest of the slides do the same, shall we? But it was just to say there's tons of forms of diabetes. The little arrow was our small group of type 2. People often say to me, aren't you getting overwhelmed with type 2 in paediatrics? We're really not. It's about 10% of the class. So the diabetes ones that can go out, because that's this talk. So we only see about 10 to 12 actual type 2s a year in Auckland. You see a scattering around the country. I know in primary care you're getting a massive explosion, but we only see the real pointy end of the sword there. So a lot of it is around type 1, because I think a lot of people don't quite get where we're going with type around the world. This is the worldwide incidence per 100,000 for type 1 diabetes. You can't read it from the back, but these are a lot of South American countries, Asian countries, China. Then you've got Middle European, Greece. And at the top of the pointy end is Finland, which has always had the highest incidence of type 1 diabetes. Are there any people from Finland here? Good. The Finnish are a very unusual population who are quite inbred and have a small genetic pool, which is probably why we think they've got a lot of high-risk genes long term. They came from somewhere, we think, in the Middle East and eventually moved right over to Finland because historically no one else was there. We are New Zealand, and this is data which is actually here from the Canterbury group a few years ago, showing we've got a moderately high rate of type 1. And we actually think that probably represents our predominantly white European ethnicity from Northern Europe. So when people say, do you see a lot of type 1? We do see a lot of type 1, and that's because we're one of the higher incidence countries in the world. This was some data from the Finns, who were the top of the tree. I can use their pointer. And we got a bit worried because they started to show that the incidence of type 1, and this was in the very young, under 5, started to really hockey stick up like global warming. And the worry is what was causing that. So this is some data from Auckland we looked at, just saying, look, we didn't see that. This was our under 5 data going back over 20 years. And we just see a slow incremental 3% rise. So when people say, are you getting overwhelmed with type 1? Well, we are, because it's a significant chronic disease, but this is our youngest, isn't increasing that much. This was our teenagers, actually, if anything, slightly at a higher rate. Essentially, this is a 3 to 5% compound increase in incidence. We think it's because families with type 1 have bigger families, mothers with type 1 are having more children, and we're seeing a lot of kids who don't come from high-risk families. So normally they're the only family member who've ever had type 1 in the family. So there are some kindreds you'll see that everyone's got type 1. We've got some families, they're usually from Holland or Dutch, and they've got 3 to 5 family members within 1 or 2 generations. 2 or 3 kids, 1 or 2 parents, uncles, aunties. That's not the standard though. So if you said to me, what's happening to type 1? Well, type 1 is incrementally increasing, and it will double about every 10 to 15 years. And that will be across the board. So if you've got type 1s in your practice, the 2 things I think you need to let them know is that their children do have a higher risk. It's about 8% if the dad has type 1, and it's about 5% if the mother has. So most adult males with type 1 don't realise they pass on a reasonably significant risk of type 1 to their offspring. If you're wondering about the Marion Pacific Island in New Zealand, this is our incidence rate in Auckland again, showing the European rate. In fact, you can see we're nearly getting up to the level that Finland had 15 years ago for type 1 in Europeans. And we do see a significant number of Marion Pacific Island with type 1 as well. So the rate, incidence per 100,000 is very similar to what their ethnic mix in Auckland is, about 10% Maori, about 10% type 1. So some of that could just be the inherent gene pool of type 1, as I showed you. Even China has type 1 diabetes. And some of that will be that there is a number of European genes in the Maori and Pacific Island population, especially if you come from Samoa. There's a lot of Germanic genes in Samoa. A lot of the Germans used to be the colony of Samoa. We don't specifically know that. We haven't looked at the gene testing for them. So if you want to know more about type 1, this is on the slide. This is from the TrialNet study that I co-run, which is part of an international group. And this is saying, well, who's at risk for type 1 diabetes? This is how much insulin they make. This is beta cell mass. They go, you've got to have the right trigger, you've got to have the right genes, you've got to have probably the ability to lose insulin-producing beta cells more than you make them. And then people go through a period where they lose insulin, but they don't get type 1, and then they get type 1 diabetes. So basically, well, maybe IGT if they're really sick, diabetes and DKA or severe insulin deficiency down here. So the TrialNet studies are part of an international USA group, and we're trying to intervene with drugs here to delay diabetes. And you'll be pleased to know at the moment there isn't anything we're missing out on, because we haven't found a single agent that will actually prevent diabetes at this stage. We've tried quite a few things. We know that a bone marrow transplant will prevent diabetes, but there's a 5% risk of death and all sorts of things with bone marrow transplant. So without being funny, at the moment, there isn't anything to prevent. So what we try to do is we actually try to pick them up early, put them into a couple of studies we're doing, and make sure they know they've got high risk. If you've got any families of type 1 in the family pedigree, there's a study called TrialNet that's open to the whole of New Zealand. It's all free. If you email me, or I'll put some email out, there's sites in Wellington, Dunedin, Christchurch. We're struggling to get people into it because most people don't know about the trial. And what the trial does, this is type 1 diabetes free, so no one's got diabetes, everyone has. And with the antibodies we measure, you can do in New Zealand, you can do GAD and IO2 in the lab, but overseas we can do a specific one to insulin, to islets, and some of the newer, funkier ones, because that's the zinc transporter 8. And really, if we can check you for antibodies and you've got one antibody, doesn't matter which one it is, your risk of diabetes is quite low. The more you have, the higher risk you are. So if you've got 4 antibodies, your risk of diabetes over 3 to 5 years is through the roof. So sorry, we want to put people in trials who have 2 or more antibodies for that reason. And this is just a couple of brief slides on children versus adults. There's a lot of work in adults trying to prevent type 1, and a lot of the drugs don't do anything. And that's because we've worked out recently that children develop diabetes faster than adults. They're not just little adults. When they have their immune process, it develops much quicker. So this is a group, this is the over 20-year-olds. So when their blood glucoses start to get abnormal, the adults tend to slowly decline. And you're probably familiar with these being the LADA or latent autoimmune diabetes in your population. Adults who you think have got type 2, but they're a bit slim and they come back antibody positive or they're on insulin. So this is adults decline further, and the younger the child, the quicker you decline. So if a child has a finger prick glucose of 20, we get them to hospital pretty quickly because they're actually deteriorating very, very rapidly. And this is just another one saying from when we get those 2 antibodies positive, the adults decline slowly, and then the younger the child, more rapid to diabetes. And that makes logical sense because the average age I look after diabetes is 9. They haven't had diabetes for 20 years, slowly evolving. They're only 9 years old. The youngest we get is down to about 1. If you wondered about, there was a trial from Auckland using nicotinamide, which is a high-dose vitamin B, which you might have heard about. Bob Elliott, my predecessor, did it. That was showing promise of preventing type 1, and this was the big European study that followed up in the Lancet about 10 years ago. And basically, those who got the treatment or the placebo all got diabetes at the same time. So if people say, why don't I just put them on high-dose nicotinamide tablets, which there will be still people in New Zealand on, it's because it didn't show anything. You can answer me for questions at any point. You can always email me. So what do we see in Auckland? Just my phrase, because we work in the biggest tertiary unit for type 1 in New Zealand. We get about 70 new cases a year of type 1. We would often get 5 to 7 a week that come in. To most general practices, that would be their 1 case for the next 3 years, but for us it's just a part of the course. About a quarter of them always come in diabetic ketoacidosis. They're pretty sick when they come in, about a quarter. And that hasn't changed for more than 15 years. So we've got about 450 kids in clinic, which for a paediatric clinic is medium-sized. for a general practice that's small, but they've all got type 1. There's about another 50 that have type 2 diabetes or other. And I was part of the insulin pump committee here at PHARMAC in this room a few years ago. Thankfully now we've got a number of children on funded insulin pumps, and I'll show a few things about pumps later on. And we have a reasonable big adolescent cohort which just completely drive you crazy. They do all sorts of weird things as teenagers. So that's the breakup of our service. We have about a significant number of Marion Pacific Island children. Our other group's getting bigger in Auckland. We see an awful lot of people from Middle East. We see kids from Kuwait, Afghanistan, China, Japan. 10 years ago that was a very rare event, but now it's much more common. I think it just reflects Auckland's multi-ethnicity. This was some data, but busy, sorry about the diabetic ketoacidosis rate. Just showing that the reason I put it up was saying that if you're under the age of 2 or 3, nearly all the kids come in really sick with DKA. Not many per general practice or primary health care, but for that family, that's a near-death experience. So the two groups that get DKA most are the very young, because no one thinks they've got diabetes. So if a GP says, I'm not quite sure what's going on, check a blood sugar or a urine, it's all you need to do. And the other group is the teenagers who are sitting in their room playing Pokemon and getting up at night to pee, and you're all in bed and you don't know what they're doing. So the group that is very lowest rates are the ones that we see the most of, which is the 4 to 7 year olds, because mum and dad know what they're up to. These kids pee in their nappy all the time, and these kids you don't know what they get up to. So we've tried to think of some primary healthcare measures to try to get a better idea of picking up diabetes here and here. I think at the end of the day the numbers here are very small, but the morbidity is huge. There's been a death in Auckland actually at the age of about 7 recently from undiagnosed type 1 diabetes. So that's over the years, just saying we didn't change much. And if you don't deal a lot with type 1 diabetes, the things that we deal with is that the kids, that they really need very small doses of insulin. You might be a 10-kilo child and you're on 5 units a day. So we're fractionating it down to 1/4 or 1/2 a unit on a syringe, or we're using a pump. We still use a lot of mixture insulins because sometimes the parents don't want to do multiple injections of the pen. They need tiny doses of short-acting insulin, like Novorapid 1/2 unit might make them have a hypo, even if the blood sugar is 20. And that's where pumps have come into their own. We have a lot of pumps in the little kids. They get sick all the time, and if you drive them too low and have hypos, or they drive themselves too high and have DKA, we know that they'll lose IQ points long term, and then they'll end up living in places further south of Bombay's, and the lower their IQ, the further down the country they go. I just said that to see if you're awake, and then it hits Dunedin, doesn't it, and it goes up again. Is that right? Okay. Just as an aside, we are seeing a mass exodus from Auckland of the poorest families. They are leaving Auckland because they can't afford it, and they're ending up in South Whangarei, North Hamilton, far south Tauranga. It's a common event. They live in Hamilton. You know where they live in Hamilton? They live in Morrinsville. And if you know from the North Island, Morrinsville is like, wow, where's that? It's sort of rural Hamilton. Why would you want to live there? It's because they can afford a house there. So the kids are growing, and adolescence is looming, which is always a disaster. Look, I just thought I'd go through about type 1. Most people don't have any idea where type 1 diabetes comes from. They ask me, is it type 1 or type 2? And I think, God, if you knew the history, you wouldn't ask that question. I went to Toronto for my fellowship. That's where insulin was made. And I always thought I'd go there and see the lab. They discovered insulin, and I see all the pictures. No, they pulled that building down. You can't even find it. There's no history behind there. So insulin's nearly 100 years old. He's the orthopedic surgeon who came up with the idea of trying to find insulin, which was an extract from the pancreas. So if you think orthopedic surgeons just heal with steel and grunt at their patients, he actually was very clever. This was the medical student who he got assigned to, who only got assigned to him because he lost the coin toss. So there were 2 students and they tossed the coin. He said, damn, I've lost. I've got to go work with that orthopedic surgeon for the holidays. And this was one of the dogs that they basically cured with the extract of insulin. If you want a quiz question, they gave the Nobel Prize within 2 years to these people, because up to then type 1 diabetes they all died from very quickly. And they gave it to the orthopedic surgeon Banting, and they actually gave it to the guy who ran the lab, McLeod. And then they, in the best institute of university academics, they had a fight with each other. They hated each other. So he gave his, shared his with the pharmacist, who's the pharmacist down the corner from Dunedin. And McLeod goes to the medical student who didn't want to work with him anyhow. So if you want to go back to the history of insulin, it's really not how you do collaborative research. Very interesting. So there's a movie called Glory Enough for All, if you want to watch it late at night. It's very fascinating. So they actually had to write one of those peace contracts between them. You will work in the lab, you won't swear at each other, and you will promise to produce insulin to save the lives of children. If you do go to Toronto, up in Toronto General, this guy was the first patient to ever get insulin. He's actually got his little book, and it's got a, like an old prescribing pad, and it says, please give Leonard Thompson 7.5 cc's in each buttock of McLeod's serum. That was the first insulin. So you think of what they gave this guy, and then he got an abscess. So not many of our patients would say, yeah, I'd like one of those, thanks. So remember, it was the horrible extract from the pancreas they gave him. It actually worked, so he lived another 10 years. That was the first insulins. They called it Arleton. Lilly came along. Lilly isn't that evil, because Lilly actually said, we can produce insulin, we can manufacture it, we can distribute it around the world. And then Nova came out and said, we can do the same in Europe years later. So without the companies, insulin wouldn't have got out of North Canada. Okay, so it was called Arleton. And University of Toronto, I think, got something like $1 for every vial ever sold for the first 50 years. They did very well. This was the first patients. This was, you can tell it's 1920s because there's a little maple leaf. You can tell it's Canada. It's got a maple leaf. If that was New Zealand, it'd be like a fern. But this was within 3 months. This is how a life-changing insulin is. Unfortunately, now we do have a group of patients who want to go back onto these restrictive low-carb diets and try not to take insulins. But 100 years ago, that was the only way you stayed alive. So basically, these patients had honeymoon phase, and they had no carbon diet. They ate like a boiled egg every 2 hours, 6 times a day. That was their entire food. So they didn't really survive. They survived. They didn't really live. And then carried on. Now, what's interesting was I went to a talk a few years ago, and this same girl is this lady. It's a bit hard to see because I took the photo as they did the talk. So this is 60 years later. So she survived with no blood test, intramuscular insulin, porcine insulin, and doctors who didn't really know how to treat diabetes because she could self-manage her diabetes. And that's her children, and that's her husband. So not diabetes isn't always the death sentence it is. There's a group who do very, very well. Unfortunately, we know long-term, this is where you know from hemoglobin A1C that your complications risk takes off with an A1C around about 8%. So that's why all the targets is 7%. This is from the DCCT. So these are all relative risks. There are patients who will run at 9 or 10% for their entire lives and never get a complication. There are runs who run at 7 to 8 and will get complications. And this is why we set the target here. So by setting the target here, we're trying to get a bell-shaped curve there. Unfortunately, most groups around the world are good if they run their mean averages around about 8 to 9, simply on the basis of that's how hard it is to treat type 1 diabetes. But we do know also if you're sitting at 10% and you reduce your A1C to 9%, you've got a 20% relative reduction in renal disease, eye disease. So going that way is always good. But there's also a group who wants to run the hemoglobin A1C about here at about 5%. And we have to say to them, you're really getting no bang for your buck. You're not going to reduce any of this risk any further because it's already less than 1. But you actually are increasing your risk of severe hypos, cognitive decline. And you actually do increase your risk of neuropathy from all the hypos. They actually can't feel things after 20 years. They also increase the risk of going completely bonkers because their parents are all over them all the time. And any blood sugar over 7, something's wrong with you. This is what the future is. This is from the Type 1 Diabetes Exchange in the States, looking at age and years over time. And this is what tends to happen with hemoglobin A1C when you hit the teenage years. So if you're sitting in general practice and you wonder why, if you see a Type 1 or a Type 2, why they're so terrible under the age of 25, that's because that's what happens. And part of this is because the male brain doesn't really mature till about 59. And the female brain is much better, it's about here. But yeah, under 25-year-old, in fact, we do quite well in paediatrics, and then the whole transition, adolescent, under 25 is the nightmare. And I don't think anyone's ever sort of worked out what you're meant to really do. So anyway, where is the best bang for buck to be spent? I'd say it's under 25, 15 to 25, there's some problem. We have the same in New Zealand, we just don't know the data because they don't come to clinic. This is the parent manual. If you ever need any of these resources, that's the website on your handout. This is our Australasian Endocrine Society. You can download the whole book. It's in PDF. You can print it off as much as you like. Talks about all different bits about diabetes for families. If you want some other resources, this is a Starship website. It's got everything to do with diabetes in schools. It's got everything about what the school should know. It's got all the treatment plans. We've got stuff there on flight plans. We've got stuff there on going to camps. And this is the sort of PDFs you can get. How to manage twice-a-day injections. What do you do if you're on a pump at school? A lot of this comes out to the fact that the Ministry of Education, if you don't register you've got type 1 and you're doing NCA or Cambridge, and you have a severe hypo or you're sick, won't give you an Nigrotat. They need to know you've got diabetes at the start of the academic year. So we actually have to sign all our kids up in fifth form and send to the ministry to say, you've got diabetes, you need more time in the exam, you need to have some time to treat a hypo or have a snack or have a brain moment. Because we had a few families who the kids were stressed, they gave too much insulin, they had a hypo, and the people wouldn't give them an Nigrotat because the ministry said, we didn't know you had diabetes. So there's actually a plan on here at the bottom, if you go down a bit further, you can just download, and the families just need to send it to the Ministry of Education. I don't know if that was news to you. It was news to us about 3 years ago. And this is all part of that too, under there. So if you haven't heard, the Paediatric Society of New Zealand has some networks. Diabetes is one of those. And one of the things we've done is diabetes in exam. So there's a whole lot of information you can just download. Tell parents, go look there. That's all on your thing. And same for anaphylaxis too, probably. But they'll probably say you ate a peanut before you came into the exam. It's your fault. Let me rip through insulins. You're okay at the moment, and then we'll have a break in about 5 minutes. So if you're wondering what sort of insulin we use, these are sort of the insulins over time. Insulins used to come in variable concentration. You use U100 pretty much all the time. But it used to come in all sorts, and eventually we worked out we didn't need those. All insulin, when you inject, it actually turns into a hexamer. So when you inject it, it binds together in this globule, and then it slowly dissociates. And all to do with new insulins like Levemir and Lantus to do with trying to alter this. So Novorapid Humalog, they dissociate much quicker. Lantus dissociates very slowly and gets absorbed. There is a pharmacist in the corner who will correct me if I'm wrong at any point in time. So the other thing with insulin, you obviously used to type 2 diabetes. The bigger your dose of, say, Actrapid, it doesn't work like Actrapid. 5 units of Actrapid will work like Actrapid. It'll be absorbed 2 or 3 hours and come out. But 50 units of Actrapid, you might as well give them Protophane because it does this. The more you give, the longer it works. So whenever I see someone on there on sort of 100 units of Actrapid, they've got renal failure, they're not on it. They might as well be on a Humalog or a Novorapid because they'll work better. So insulin depots and it clumps and then it delays absorption. And in your handouts, just if you didn't quite know what all the new insulins are, we standardly use Novorapid, which is an analogue with, and Lysopro is there as well, relatively rapid onset and about 3 to 4 hours action. NPH is your Protophane as well, medium. There are a whole lot of new insulins. Apedra is funded now, is a little bit more quicker acting, but if you look at it, it's still got a quite long tail. Levemir is signed off by PHARMAC about 7 years ago, but still not funded. Did I say that in the PHARMAC office? But anyway. Lantus you'll be very well aware of. Doesn't actually work like that. That's stylized. It sort of works a bit like this, drops down and comes up again. And I'll show you later on what the new insulins are coming. People ask me, why don't we just inhale insulin for kids? The answer is we did. This is called the Exubria device, made by Pfizer. They spent billions making it. They got particularized insulin, so you could inhale it. So you had 2 units, so you could have 2 puffs. Went out to market and completely crashed and burned. Not a single person wanted to buy it. No one wanted to carry this device around in their pocket for every time they wanted a shot of insulin. And then they worked out that people who had underlying lung cancer, it caused the lung cancer to grow very rapidly. Because insulin is a little bit mitogenic, or it causes things to grow. It doesn't do it subcutaneously, but if you throw it onto a cancer in your lungs, it will. So we think we dodged a bullet there because the market didn't want it. Otherwise, I think you'd have found there'd be a lot of people having lung disease from having inhaled insulin. So, and insulin also does something funny. When you show it into your lungs, it actually causes amyloid deposits or cross-hatching, and it causes patches to stick in your lungs forever, which is not really something you want. You might be familiar with the insulin pumps. This is a couple of old versions of pumps. They're now PHARMAC funded under certain criteria. Mainly use this pump here, the NMS Vibe. Very swanky pump. The Medtronic version is this one. If you've got kids on pumps, they normally mean they're from a fairly highly motivated family. PHARMAC funds the pump every 4 years under certain criteria and the consumables and lines that go with it. So every pump isn't magic. You've got to get in the insulin from the pump to the skin, so there's all sorts of cannula and devices. So these are all, this is plastic, this is a metal straton device. This is a metal straton with a sort of a safety loop. So if you tug this bit off, you're still actually stuck in. They're not magic, you've still got to push the buttons. If you've got allergies to metacrystal or any preservatives or tapes, they're a nightmare because they're stuck on you all the time, so they cause a lot of reactions. And we get lots of people who are allergic to Teflon. These are Teflon coated, the plastic ones. So if you're allergic to Teflon or stuff like that, you get in trouble as well. So what pumps do is they're not magic, but they can deliver a tiny dose of insulin in the background, which can sort of mimic what you do. So we could put a pump on and give you 1 unit an hour of Nova Rapid, and it will deliver 60 little increments of Nova Rapid an hour. So of one unit in total. And if you want to eat, you can have an insulin over 3 minutes, or you could have over 20 minutes, or you could have a bit of both. And if people come in saying, I wanted a dual-way bolus on my pump, don't get freaked. What they're meaning is, I'm eating pizza and I'm going to give some insulin straight away for the topping and the rest for the base. They're just families who can actually understand what you do for insulin. On an injection, you can just give insulin. You can just give it all at once, 4 units of Nova Rapid. On a pump, you can give 1 unit straight away and 3 units over half an hour. So there's all sorts of nuances of pumping. I'm going to flick through that. So the 2 criteria for pumps are recurrent severe hypoglycemia and erratic control. We use a lot of this criteria because the definition of recurrent hypoglycemia is needing assistance from others. And if you're a 3-year-old child and you're at 2 in the morning, who is helping you? Your parents are helping you. So it's actually easiest to fund a pump in anyone under 5 because parents do most of it. It gets trickier when you're a teenager who won't even let you do anything to them, including make their bed, because you shouldn't be making their bed anyhow. But the criteria uses that one. We just find that people who have poor A1Cs don't do as well on pumps generally. I just have flicked through a little bit of new stuff. You might have heard of something called glucose monitoring. The 2 pumps PHARMAC's funded are actually future-proof. They've got the ability to pick up a glucose sensor and read it on the pump real time for any patient who's got one. The glucose sensor, though, isn't funded, but the pump is ready to go. So it's a bit like buying a new Volvo which can do self-drive. It's ready to go, it's just that you can't do it quite at the moment. So the glucose sensing is these little devices you can buy. They have a little wire which senses glucose and they transmit it to the pump. So there's one of these inbuilt into every pump. And these are tiny. They have a little bit of a lag on them. So you're not really meant to just look at it and say my blood sugar's 5, I'm good. That was 5 minutes ago. So if you're feeling weird on it, it could be that you're hypo right now. And this is the sort of tracing you get out of it. So someone can actually just wear a pump and go, oh, I needed more insulin for breakfast because I excursion, but the rest of the day wasn't too bad. They're coming out, their families are buying them, and there's even a new version. So they look a bit like this. This is a pump site. So insulin's getting infused to the pump here, but that's actually monitoring glucose here. So the next version, which is probably within 3 to 5 years, is they're going to get the 2 to talk to each other. And then you can not have to have the adolescent brain in the way. And therefore, we might have better diabetes control in some of our groups. Especially overnight. If you can link the 2 overnight, you'll have good blood sugars. This is how often people put them on the arm. This thing doesn't, you don't run around with this thing on. You're just running around with that on, if you're just wanting to know. And this is the little transmitter device. So you can just actually do sensing without a pump. And there's a lot of people around the country who don't want to wear a pump but want to know what their blood sugars are. If you're overseas, you can get a pump like this, which is what Nick Jonas, I think, wears. Nick Jonas? No, you guys are either too old or too young, or it's from the Jonas Brothers. He's apparently famous, but he's got diabetes, and he promoted, this is the Omnipod, this is the entire pump. It just sits on you, the needle goes in here, you infuse from here, and you just stick it on and you run it from your iPad type device. We don't actually have these in New Zealand, but quite clever. Problem is, if you're allergic to tapes, the whole thing is taped on you. And you can run around, that's the entire pump system in a little bag. So that's the new pump, that's the backup pump, that's your insulin ready to go. Lots of other pumps around in the world. If you go to society meetings, they're just like cars now. So PHARMAC's going to have to look at different new ones. This is more of a touchscreen pump. This is a tiny pump, that's how small it is. Just run from your iPad. There are new insulins. I just told you about the insulin curve. What else is coming for PHARMAC to think about, which I don't think we'll fund because there's amazingly expensive, is this is a bio-chaperone humalog. So this is standard humalog in green, and if they spend millions of dollars and put a new protein with it to make it absorb quicker, you can make it go in about 10 minutes faster for a cost of about $1 gazillion. So when PHARMAC looks at these, and I sit on the committees, we say, well, what is the clinical benefit of this? Not that much. So you can make them faster, and there's lots of studies and people out, they've all got the new fast insulin, but you can also make insulin longer. This is Lantus. This is not really what Lantus looks like, this is the schema. But what they've done is they've gone Lantus and they've smashed 3 times more Lantus into a smaller sphere. And by doing so, when it dissolves, it takes longer to dissolve. So there is now going to be U300 Lantus coming along. It's in the States at the moment. So you're using U100. So they're going to have a Lantus that's going to work 3 times longer with 1 injection. You can imagine how that's going to disrupt the type 2 diabetes market. Those families that can't take the insulin, you can give them twice a week Lantus and you'll keep them out of trouble. So I don't know what sort of rebate PHARMAC was going to do for this, but it's going to cost a bomb. But it's going to be very interesting because we all have families in our clinic, type 2 adults, children, etc., who basically don't take any insulin. So yes, U300 Lantus is coming, which is interesting. So one is really, really quick. One is just get the basal right and really, really long. So I think as practice nurses and GPs and primary care, that's going to be a market disruptor. That might change the play. Because if you miss a few doses of it, it's not the end of the world. It's got such a long half-life. A little bit on glucose monitoring, and then we'll have a tiny quiz. This is out there in the market. This is called the Abbott Libre, L-I-B-R-E. It is not a sanitary pad. That is what they actually called it. It's from the UK. It's a little button-type device you wear on your skin, and every time you want a blood sugar, you get the meter, and you don't do a finger prick, you just flash it over, and it says, this is your number. So if you want to flash it over 30 times a day, it'll tell you what the number is.
60 minutes or something.
Yes, it was and it's just getting press. It costs about $300 to buy the system, $100 each, last 2 weeks. You have to do maybe 2 finger pricks a week for your child with diabetes if you want to. Yeah, so this is another market disruptor which is out there. And the thing with this one is it's going to save money in glucose testing, because families with this on will say, well, I don't do 6 tests a day anymore, I do 2 a week. So this is really going to, this is called the Abbott Libre, fascinating device. It's called flash glucose monitoring, literally flashing it and saying the number. At the moment you can't buy in New Zealand, but you could buy in the UK and use New Zealand post box shop drop thing in the UK, and then they'll send it out to us. That's what the families are doing. Just launched in Australia. Yeah, and Christchurch has got a little clutch of wealthy families who've ahead of it.
Yeah, and we've got some families in Christchurch that have found it so successful with their children. They've bought more in from overseas and donated them to our team to give them to families that need them.
Yeah, and I think the minute it's funded,
which is incredible.
So they need to write letters of support for this thing to be in the country, I think. I think the stress level goes down in the families.
Yeah.
Yeah.
And they're using their child disability allowance to pay for the $100 a fortnight.
Yeah. So at 3 in the morning, if you want to know if your kid's hypo, at the moment you've got to semi-wake them up, do a finger prick, and these days you can just go up and go. We don't normally put it on the forehead though. we normally do it. Yeah, and which is interesting. The parents go, oh, okay, that's what you are. And if you really want to know the future, if you were wanting to go to a research study, you could actually have, this is the first commercial artificial pump. So it's not really user-friendly. They need a bit of design improvement. But this pump is sensing glucose, it's delivering insulin, and it's delivering some glucagon if you're a bit low. So it's doing everything for you. So they're not far away. I think practically in our environment, it's probably a decade or 2 away, but they're really close. Now, this is my last slide. There are some other stuff on calcium cases, but I'm going to leave them in your talk because I want to get on to the middle quiz and then get on to some growth. If you're really, really clever, these are coming out. These are little tattoo-type devices where a wearable bio-sensors will check your blood sugar and check your heart rate and check everything else. And you'll just literally have one on your arm for 2 or 3 weeks, then you'll peel it off and come back in again. Of course, this is all pie in the sky stuff, but for diabetes, this is a life changer. Yeah. So these are all the biotech companies that want to earn you millions with the promise you might do successful.